It's hard to take care of children with malignant disease because your heart and soul goes into every patient that you have. And some of them have very, very hard to cure cancers. But we never give up. We never give up because we don't really know who's going to do well and who's not going to do well. We know what the statistics are, but it's hard to keep up that pace and be optimistic for a long period of time. In Michael's case, he's been doing this for close to 50 years.
Well, I was trained as a hematologist, but what I needed was an oncologist. I was asked to combine the divisions of hematology and oncology, and Michael was an up-and-coming oncologist in Boston, and he was my first recruit in 1979, and it was one of the best recruitments I've ever made in my whole career.
Michael fit the bill. He was particularly interested in pediatric lymphomas. We had a very, very strong lymphoma program at Stanford. We had a new children's hospital, but the hematology-oncology section needed to be spruced up, and Michael was fit in like he'd been at the table forever. Everybody loved him.
My brother was really the biggest influence. He's only 4 years older than me, and he was bound and determined to be a physician. He was a resident at the Mass General Hospital, and he encouraged me to come to Boston because he said, first of all, we could spend time together, and second, that I would have the opportunity to sort of navigate in programs which were very helpful in your subsequent career. I spent 5 years there doing my internship, residency, and fellowship there, and my brother was right. That is still the single best rotation I've ever had in my whole life. Now, when I was a fellow, I never really liked taking care of kids with osteosarcoma. Most of the patients required amputation. Most of them are teenagers still, and had to go through this very painful process. But at the time, there was a great controversy as to whether chemotherapy had any impact on the outcome. We'd go to a meeting and hear people sort of scream at each other about whether chemotherapy actually had made a difference in this disease. And I was a sort of a junior naive guy, and I said, well, if you just did a study, a randomized trial, you could have the answer at maximum a couple of years. You might have it sooner. And another one of my mentors, Teresa Vietti, just challenged me and said, go do it. So, I did.
And he ran it, and it showed the value of chemotherapy, and now chemotherapy is established as standard treatment worldwide.
It used to be about 80% of children did not survive having a cancer, such as lymphoma, leukemia, and a sarcoma, and 20% survived. And he has been one of the oncologists and pediatric oncologists at the forefront of his field, this giant in his field, really, where the tides have completely turned. When we treat children with cancer, we're using a lot of the research that he has done to do these treatments.
I was really interested in was lymphoma. And this was a very important time in the management of lymphoma where patients with non-Hodgkin's lymphoma, the majority of patients were, especially those that presented with advanced stage disease, were dying. The standard treatment for the management of localized non-Hodgkin's lymphoma was to give radiation therapy and then chemotherapy.
Our goal is quality of life as well as survival. So the question was, is there a way that we can cure patients and have fewer side effects and tailor the treatment to the appropriate severity of the disease and avoid using radiation? And so to answer that, Michael wrote a prospective randomized trial.
We ran a study where we simply randomized patients to get the same relatively non-intensive chemotherapy regimen with or without radiation.
Proving that children with localized non-Hodgkin's lymphoma could be adequately treated and cured without using radiotherapy was a very important observation.
I think one of the most wonderful aspects of being a pediatric oncologist is to watch a patient mature, go through perhaps the worst part of their life, but be a very important part of it, and then go on to do the things that they were hopefully going to do with their lives. And I don't know that they're left unscarred, but the idea that you got them through this very dark time of life is a treasured thing.
What's amazing about Dr. Link is I like to think that I'm his favorite, but I've talked to so many of his patients and they all feel the same way, which is that he's their friend, he's their confidant, and above all, he's their hero. He's my hero, and he's inspired me to do everything that I do, which is wild when you look back on it, that I had this experience as a resident in the place where I was treated, which is incredible. And Dr. Link was there. I mean, just what a special person he is to see his patients come full circle, really, where I can be a patient and then 15 years later be a doctor to the patients that he also takes care of.
Well, it's like the triple threat in football.
He's the triple threat.
And you got to run, pass, and kick. Michael does it all. He's a great doctor, a great clinical investigator. He's made major breakthroughs, and he's a great teacher.
Right now, I would say that Michael's passion in life is advocacy for childhood cancer. He started something called the Alliance for Childhood Cancer. He's taking the problem not just from his own patients that he cares dearly about, but to a higher level.
He was the first pediatric president of the American Society of Clinical Oncology.
And now he's taking it to the level of policy and the government.
He travels to Washington, D.C. a lot and talks on Capitol Hill about fair and equitable access to care.
He just keeps climbing higher mountains to solve a bigger problem.
I don't think I'm going to set the world on fire with another study, but what I can do is really work to make the lives of children with cancer better in any way possible.